Hi, I'm Frank Spear. I want to thank you for joining me on this segment. We're going to talk about in this segment something that I think is very confusing for a lot of dentists, and that is the whole concept of, do we connect implants and teeth? And more importantly, what actually is the mechanics, or what are the risks when we connect implants and teeth? And so it's a question that I've been asked a lot in almost 30 years of education, and most people talk about it as though there's a one answer. You either say yes or no. Like most things in dentistry, that's not it at all. There's actually multiple right answers. Sometimes it's perfectly safe to connect implants and teeth, and other times it's not at all safe to connect implants and teeth. So what we need to understand is we need to understand the mechanics of the whole process. And then we need to identify what cases would it be okay, why might you actually think about doing it, and when would you really be at risk if you did it. So let's just start with some very simple mechanics. What exactly happens when we splint anything? Whether it's two teeth, whether it's a tooth and an implant, whether it's two implants. And it's actually quite simple. As soon as you splint things together, the forces that are applied to one of the teeth now affects the other. So if it's a tooth and an implant and you apply a force to the tooth, it affects the implant. If it's two implants, it's the same thing. And it doesn't matter if it's an occlusal force, it's going to then affect the other tooth, or if it's a buccolingual type occlusal force, it's going to affect the other teeth. So fundamentally what splinting does is the forces applied to one now impact the other, which of course is a valuable thing in certain cases, because often we can use splinting to minimize torsional stress by having the other splinted teeth negate the effects of the torsion on the actual tooth that the force is being applied to. So when we think about it, and we now start thinking about implants and teeth, as opposed to just splinting some teeth, this is sort of a classic illustration. Here's a 3-unit bridge. There's a single tooth implant attached to a premolar with a 3-unit bridge. And the question is, what are the risks? Now, in the early days of implants, 1980s in particular, this was incredibly common. We're trying to save patients money. We didn't know about some of the complications that occur. And so it was very common to put one implant in and do a 3-unit bridge to a tooth. And in fact, with some of the early implant systems, there wasn't any anti-rotational abutments. They were all just cylinders. So if you were trying to do a single molar implant, you pretty much had to connect it with some kind of an attachment to the adjacent tooth so that the molar didn't simply rotate and come loose all the time. So the connection was actually a very common thing. Probably the person who wrote the most about it back in that era and became very famous in terms of the implant literature was a fellow named Bo Rangert. And this is sort of the classic Rangert article in 1991, where he talked about the mechanical aspects of connecting a Brannemark implant to a natural tooth in a laboratory setting. And he actually did exactly what I illustrated here. He took a block of acrylic and he placed an implant in it, and then he took an artificial root and placed it in, but he gave it a periodontal ligament of silicone. And then he did a 3-unit bridge, and he actually measured the amount of stress and strain transferred to the different components when he loaded the restoration. Now, to understand his conclusions, you really have to understand his model system.